Hello, my name is Libby Sallnow and I'm the author of the chapter on prevention and harm reduction in the textbook. I'm a palliative care doctor and clinical academic at St Christopher's Hospice, the palliative care group at UCL, and my NHS time is at Central and North West London NHS Trust. I'm also a part-time researcher at the VUB, University in Brussels, and an honorary consultant at the WHO Collaborating Centre for Community Participation in Palliative Care in Kerala, India. I'm going to talk through a few slides to capture the essence of the chapter that I wrote. And of course, there's much more detail and more background in the chapter. So this is aimed to give you a taster of the key themes. The easiest way to start understanding what this chapter is about and what the role of prevention and harm reduction is in end-of-life care, I think is summed up by the river parable that I include in the chapter. And this river parable describes a doctor walking along the side of a river. They hear a scream and they go to pull someone out of the river who is drowning. They resuscitate them, but before they're able to continue or do anything else, they hear another scream and they go in to rescue that person and again resuscitate them. And this continues with many people needing to be pulled out and resuscitated, meaning that doctor is unable to take a moment to understand what's happening and crucially to look upstream to understand why these people are falling into the river and what could be done upstream to prevent this happening. They're essentially in crisis management rather than upstream prevention. And that really goes to the core of what a new public health approach and what a public health approach aims to look for all areas of health, illness and disease. And it's something that we assert really has been neglected and not focused on within the end-of-life care field. Alan Kelleher often uses the example of heart health, not beginning when someone arrives in an emergency department with a heart attack. That is not when we first start thinking about how to manage someone's health, someone's heart, and how to improve and reduce the risk of that event happening. And similarly, in end-of-life care, we do not start thinking about how we support people at these times, their families, their loved ones, their wider community, when someone is dying of a life-limiting illness. Those thoughts should take place much earlier upstream. When we think about prevention, there are different levels of prevention. So there's primary prevention, when you're looking really to prevent the disease starting. So for example, vaccinations programs are a good example of that in public health. Then there's secondary prevention, also known as early intervention, when a disease has been established, but you're looking to minimise the effects of that disease and reduce those. For example, screening in cancer to find examples of cancer early, or reducing and managing blood sugar if someone has diabetes. And then tertiary prevention or harm reduction is really when a disease is very established and you're looking to minimise and reduce the harmful impacts of that. For example, doing rehabilitation after someone has a stroke, or opioid substitution to safer opioids if someone has dependence on opioids. So those are really well established in the public health fields across many different areas. And the question we ask in this chapter is, what are the primary, secondary and tertiary level interventions for prevention in death, dying and grieving? When we are looking at how you begin reducing, harm reducing or preventing the issues related to death and dying and grieving, you need to look first of all at the broader context within which these take place, and specifically the social and structural determinants. Now, the social and structural determinants of health and well-being are really well known. We know a lot, there's a great deal written about the role they play in people's health in the broader sense of well-being, and they underpin, for example, the Sustainable Development Goals and many other broader thinking around health, around how health is determined by more than just health services. And this idea of social and structural determinants of health often has omitted death and dying and grieving. Often by the time you have the diagnosis of a serious illness, or you're grieving for someone who has died, the sense is that actually nothing can be done. You know, someone is dying, and that's where kind of intervention and harm reduction interventions stop. But we assert that actually there is a great deal that can be done. And the concept of social epidemiology describes how when people are facing issues of death, caring, dying, and grieving, there are many things that can support to make this time better, but there are many things that can undermine this time and make it much harder. And how the social environment, the institutions, structures, relationships influence these times is really the study of social epidemiology and of social and structural determinants of death, dying, and grieving. So in the chapter, I go through how these different determinants affect experiences of death, dying, and grieving, and crucially how they can be improved, changed to improve and change these times and these experiences. Looking beyond just the structural situation for how people may experience death and dying is the human rights-based approach. And this goes beyond looking at the needs people may have, the influences that where they live may be having, and the relationships they have may be having on these experiences, to look more critically at the rights they have, and crucially the role and agency they have in changing these experiences for themselves, rather than new services being created to meet these needs. And we see that this is not a one-way relationship. This is much more of a cyclical relationship. So whilst poor experiences with death, dying, and bereavement can be a consequence of marginalisation, disadvantage throughout life, so they can be drivers of that further inequity, disadvantage, and marginalisation. And this diagram captures this cyclical relationship between how people live, how people die, and how people grieve. So starting with the top right, with the social determinants of health, this is something people are often familiar with: the role, economic stability, conflict, education, neighbourhood, determinants, food and nutrition. These have huge implications on how people live, their health and well-being. But these determinants also feed into how people die, and they can be understood as the social determinants of a healthy death. And these things can be more specifically around this time, such as the role of networks, carers, access to opioids, the ability to reflect and find meaning and coherence at this time. All these determine how someone will experience the death themselves, but crucially how those around them will experience that death. And how that death is experienced feeds into how people will be grieving those left behind, and the role of social networks, the role of supportive policies, for example, through workplace or the broader social setting, the availability of professional services for people who may need that, and the understanding of when and when not to do that. So this feeds into how people grieve. And then how people grieve, the role that death and those caring experiences, how they influence that person, feed into their future lives and the lives of others, and how people can go on to live well and live in a healthy way. So this diagram captures this cyclical interaction really between living well, dying well, and grieving well, and how it can become virtuous with improved experience of living well, can lead into a better and healthier deaths for people, and better experience of grieving, which feeds then into living better lives in the future. But also poor determinants of health can lead into poor determinants and poor experiences at the end of life, and poor experience of grieving feed into living further unhealthy lives. So this cyclical way of describing and understanding that is really crucial to understanding how we can influence, prevent and harm reduce social determinants in death, dying, and bereavement.